Patients often come in and ask, and this is what the question was, how do you get a workup for gastroesophageal reflux disease or GERD? So this can be a complicated question, and it depends really on how you've been treated and if we think you have GERD at all. So to break it down simply, if a patient comes in to me and says, I think that I might have GERD, I've been taking over-the-counter Prilosec or Nexium or Tums or something of that nature for quite some time, I'll listen to the story, we'll talk about the symptoms, and then we begun a whole host of diagnostic tests. And so the things that we want to look at are objectively quantitating the GERD. So are you having reflux? And we can do that several different ways. One, we can do some pH testing, which is to say we go down and see if there's put a small probe in and see if there is in fact acid reflux. We certainly want to start with an endoscopy often, where a gastroenterologist or someone else goes down and looks at and takes a look at your esophagus and stomach to see if there is any damage. And there are other tests like radiologic tests where we can start with an esophagram and just simply take a look radiologically at the esophagus and stomach. That gives us a lot of information. So depending where you are on the pathway of your diagnosis and what kind of treatments you've been going through, that's where we'll bring in some of the diagnostic tests that we have available to take a look at GERD. Well, it's often a question of when should I get tested? And so this can be a tough one. I think that it depends on age and length of the disease process. So if you come in and say, well, I had a great dinner a couple of nights ago, and I had enjoyed some wine and had a big meal and had some coffee, I would say, well, really, if you have reflux after that, that would be normal. Maybe, take some Tums every once in a while. But if you are the type of person that has been on, say, Tums to begin with, you then started taking Pepcid or Zantac, which are H2 blockers, a specific category of drug, and then you had to move on to something like Prilosec or Nexium or Dexilant, and you've been doing this for years and years, why then I would say we need to really start looking at doing some testing. So the more simple answer is that if you've been suffering from GERD for 5 years and you haven't had an endoscopy and or an esophagram to take a look, then I think that that's where I would start. So 5 years from the time of diagnosis or when we really think you start having GERD symptoms. But more importantly, there are a whole host of what we call alarm symptoms that would immediately make us think that you need to have an endoscopy. And those alarm symptoms are these. Number one, it's dysphagia, which is a fancy term for trouble swallowing. Odynophagia, which is another fancy term for painful swallowing. Then if you're having chest pain that we know is not from your heart, that's not good either. Another one is having gastrointestinal bleeding. So again, reflux can cause damage to the esophagus and the stomach and cause bleeding. Hiatal hernias can cause bleeding, and so we want to be able to detect those. So if you are, for heaven forbid, having blood coming up in, say, in vomit or something like that, or more commonly see it in your stool, that would prompt us to do an endoscopy and search out the reason for that. Or you have anemia by a blood test. A lot of people are anemic, and sometimes GERD is an unrecognized diagnosis for that. And finally is unexplained weight loss. So if you find that you're losing weight and you can't keep your weight on, then we worry about that. And all of these are really signs of severe disease, severe end-stage GERD that may even be a harbinger of cancer. So we don't want to miss these. That would lead us to getting an immediate endoscopy, and that's certainly a pathway into the diagnosis. And with GERD, it really is a disease. That's why there's a D in GERD. And so if you have ongoing damage to the esophagus, that leads to inflammation and healing and inflammation and healing. And we know that some patients will progress on to a condition known as Barrett's esophagus, a condition that I suffer from as well. And Barrett's esophagus, quite simply, is where the lining of the esophagus changes into the lining of the stomach. Your esophagus says, hey, I'm tired of getting bathed in acid and bile and everything else that's coming up from the stomach, and I just want to turn into the stomach and it'll be a little bit easier on me. The problem is that when you do make that change, when your body makes that change, there are lots of DNA shifts, and that can lead to cancer. So we know that patients with Barrett's esophagus have a 40 times greater risk of developing esophageal cancer, and really this is often downplayed by either primary care doctors occasionally or more commonly gastroenterologists, but that rate of progression to cancer is about 0.5 to 1.4% per year, which sounds like a pretty low number, except for if you think you're going to live 10 years and you have a 0.5% chance of developing cancer, that's 5%. If you're at 10 years and it's 1.4% chance, then that's 14% chance of developing esophageal cancer, which is an extremely deadly disease, killing 85% of the patients by 5 years. So we certainly don't want that. Barrett's esophagus then has several different categories. Those are no dysplasia. You can have dysplasia in your Barrett's, and then high-grade dysplasia, which we really treat like cancer, and then full-blown cancer. So that's the natural, that can be a natural progression of the disease.